Hello everyone, Kent.Bressler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, podcast endorsed and sponsored by kidneysolutions.org. Hello, everyone. This is Kent.Bressler. Again, we're going to do some podcasting this morning, and I have a very learned guest that I think you're going to enjoy listening to. This is by the time you listen to this, we're nearing Easter, and I just want to let everybody know that there's a lot of grief that's going on, but Christ has come to us and He's saved us. So not to worry. Pay attention to the fact that you are here because He wants you here. He needs you here. So let's start this morning with prayer. Lord, death could not hold you, and because of you, the resurrection, we too can live. Thank you that the grave is only a journey into the presence of God. You have removed the sting of death and empowered this thing called life. Now, I will live in your presence forever. Amen. So, I want to introduce to you this morning, and I must admit my names are not good, but I'm going to make a great attempt at it, and he can correct me later on. Fouad Chebib, who is
What?
we're calling Dr. Fouad. How's that?
Sounds good.
I want to tell you a little bit about him. He's a nephrologist, and he's an expert in hypertension, and his expertise is really actually the management of PKD, Polycystic Kidney Disease, and its multiple complications. He's likes to be considered also in the clinical activities. He's also active in research and education, and he provides mentorship to residents and fellows. He authors expert content and publishes in high-impact scientific journals. In Dr. Chebib's laboratory at Mayo, researchers examine molecular mechanisms that lead to cyst formation in ADPKD patients and explore targeting treatment options. Dr. Chebib is specifically interested in the intracellular calcium and CAMP signaling. Now, what we're going to talk to him about this morning is genetic testing. So, Dr. Fouad, how are you this morning?
Doing great. Thank you. Before we go in, I'm going to say thank you for the prayer. And I want to acknowledge there's a lot of grief out there with COVID and other things, but also with just being a patient with kidney disease. There's a lot of worry about the pandemic, about having a kidney disease, about your loved ones, and what's going to happen. So that uncertainty brings a lot of anxiety. And then with Christ, with the resurrection, a lot of things make more sense with the grief of losing loved ones. So thank you for pointing that out.
I want to bring that right up this morning. You have lost a loved one. Can you tell me about that?
Yeah. So it has been a difficult few weeks. I lost my father, and I can say we lost him for the battle to the kidney disease, because a lot of things are connected to having kidney disease, being on dialysis, and so forth. So we lost him about 40 days or a little bit more ago, early February. He was my inspiration to become a kidney doctor, and specifically in an expert in genetic kidney diseases and polycystic kidney disease in particular. And he inspired me to really try to find a treatment for this devastating disease. So he had polycystic kidney disease, was on dialysis for about 3 years, got a transplant for about 21 years, and he passed away from a complication from polycystic kidney disease. And it was very, very difficult. And, having the resurrection, the faith that, his life has just started, brings a relief for us, although it's still very difficult to kind of navigate that. But definitely the past year has been very difficult on probably everyone has been affected one way or the other.
Yeah, my condolences. My love for you and your family is deep. I cannot believe how difficult it is. I've lost my father, not to kidney disease, but to the advancement of age. You had 21 years with him as a transplant patient, and that's the joy of transplant.
Absolutely, yeah. He always says each day is a gift from God, because when he was dialyzing, he thought he's not going to make it. He was all of a sudden got into kidney failure on dialysis, middle age, right in his 40s, and full of energy, and he has to provide for his family. But all of a sudden, they tell you have to stop everything, and you have to figure out you have to go through dialysis. You're going to be wiped out after dialysis.
Oh yeah.
So when he didn't think he's going to make it, and after he got the transplant, he was the most grateful person I've ever seen, because anytime we complain about something, he's like, don't complain, and then he always feels that transplant was it was a gift and a second lease on life. But it wasn't only for him, it was also for us. I wouldn't be a physician if he didn't get it.
Yes, absolutely.
It has such a large ripple effect that I always mention, because people start to say, okay, we shouldn't do this treatment or that treatment, it's too expensive, we should do this or that. Like, please stop, because each person who you save through this kidney transplant, you're saving not only him, but a whole circle in the society that helps.
Oh yeah, you're saving life, actually, what you did, and you're providing an opportunity, like you said, for you to go on and do what you're doing now.
Exactly.
This is spectacular. And we could talk about him all day long.
Yes.
We could talk about it, but I'm going to tell you what, we're going to move forward, and because that's what he'd want us to do.
Absolutely.
All right. So let's talk genetics. This is a topic that I think it's something that needs to be addressed, and we're going to try to go through as many things as we can, but we're not going to rush at it. Okay. So how are genetics and kidney disease related? How do they relate?
Well, so if you want to be a little bit philosophical about it, everything is genetics. Everything is what we inherited and how it interacts with the environment. But we're going to be less philosophical, more practical. And we're going to talk more about the known genetic kidney diseases, or what we call monogenic diseases, which means there's only one mutation, one gene that is affected. And if you have a mutation in that DNA, so if you have a defect in how the cell and the body makes that protein out of that DNA, out of your genetic background, that defect in the protein is going to cause a problem, and that problem is going to cause a disease. And we're going to specifically, over the next, in this session, we're going to talk more about these diseases that are caused by one defect that we can talk about. So it's very common. So genetics and kidney diseases is becoming even more, we understand more about it. Just to give the background, there's at least 1 in 10 people in the world that have chronic kidney disease. So 10% of
10%. Yeah. Okay.
So if you have a group of 100 people, at least 10 out of them will have problem with their kidneys. Now, out of those people, most commonly it's going to be the diabetes, it's going to be the high blood pressure, which is also a complex thing. A complex topic is, does the high blood pressure cause the kidney disease or vice versa, and so forth. But we usually divide them into diabetic kidney disease, hypertensive kidney diseases, and then the glomerulonephritis. So we'll talk more about that. And then there's the inherited kidney disease. So that comes after those. So, and there are some inherited kidney diseases that can cause glomerulonephritis and high blood pressure and other things. So
right, that's part of like FSGS.
Exactly.
So some of that is genetic, but it's not all genetic.
Exactly.
Okay.
Exactly.
All
right. So there's probably hundreds of kidney diseases that are caused by gene defects, and we can probably divide those genetic diseases into the disease that can cause kidney cysts, or these fluid-filled sacs that kind of grow and cause the kidney to get damaged and then lose kidney function, such as autosomal dominant polycystic kidney disease or autosomal recessive polycystic kidney disease, the childhood form of PKD. There's the defects in genes that can cause the glomerulopathy, which is the defect in the filters. So glomeruli are the filters of the kidney.
right.
So we have two kidneys. Each kidney has millions of these filters called glomeruli. And then each of the filter is connected to tubules or small tubes where the filtered blood becomes kind of urine, and the urine goes through a processing, and then it becomes the urine that goes into the bladder. So the defect that are caused on the filter, like FSGS, what we call primary FSGS, or the genetic causes, they are causes in complement, so the immune system type thing, and those can cause glomerulopathy. And there's the most common one is Alport syndrome. So a lot of
Alports, yes. Mm-hmm.
So many, or what has been called hereditary nephritis. So it's a defect in the collagen. It's a defect in that gene that can cause problems on the kidney filters, but also other problems like hearing loss and eye issues.
Right.
So those are probably what people would remember. There's other more rare things like Fabry's disease, cystinosis, and other things. There's probably not enough time to talk about all of them, but this is kind of the most common ones.
Well, that's the overall. People think of kidney disease as something specific, and it's not. It's very diverse. It's like there's multiple, like you just explained. So
yeah. So there are things that can affect the filters, the glomeruli. There are things that can affect just the tubular interstitium or the supporting tissue of the kidney. It becomes kind of scarred. So those are tubular interstitial diseases, and those can lead to kind of scarred kidney and then kidney damage and kidney failure at the end. And other things where things kind of deposit on the kidney because of a problem with that protein. So try to simplify it in that, kind of put it in categories so it's easier to understand.
So let's get over into the finding out about it, the genetic part of it. Say I'm on dialysis, or I have already had a transplant. Okay, so what's the point of knowing whether or not I have a genetic form of the disease?
Yeah. So that's an excellent question, right? So once a patient is on dialysis and they got the transplant, they kind of feel, okay, well, why do I worry about what caused the kidney problem? Well, there's a lot of important information that comes out of knowing what caused my kidneys to fail. So one, if, for example, the transplant, you want to make sure that the kidney disease is not going to come back to that kidney, right? So always having an accurate diagnosis helps the management, whatever happens after. Because also some diseases can have other damages on other organs. So it doesn't have to be only the kidney. So always having an accurate diagnosis is important. And it's not always the case. So a lot of times when patients come in, they have kidney function of 15, 20%. We do the kidney biopsy, and then it shows just generic scarring and damage to the filters and to the tissue of the kidney. And we say, okay, chronic kidney disease of unknown cause.
Yeah.
That's has been bothering us as nephrologists, and we're trying to get through it. And this kind of tackles it directly to the genetic, because a lot of these causes could be genetic causes.
Right.
So this is where getting a biopsy, prevention and trying to detect the kidney disease is the first part. But let's say somebody came in on dialysis or got transplanted, and the biopsy is not going to be informative. then genetic testing is an important part of it, especially if they have a family history. So there's about a quarter of the patients would have a positive family history, 25%. And then a lot of those patients, so in adults, we say about 10% of the patients would have, we can say for sure this is caused by this particular gene. And then in children, it's probably much, much more, because most of the children, if they get into kidney failure, it's probably something most of the times it's inherited. So in general, there's a lot of people who say unknown cause of end-stage kidney disease. So getting the genetic test is going to inform us about the diagnosis. So that's going to inform the patient and the team if there's anything else they need to look for, if the disease is going to recur on the kidney and we need to do more regular monitoring. And then the other thing, which is very important, is the family, right?
Oh,
so,
yeah.
So that comes very important. One, if the patient's family want to donate the kidney, so you want to make sure they don't have the same kind of risk factors or the disease. And second, if there's no donation involved, they want to know early on if they can prevent things. So if we do early diagnosis, let's say Alport or Fabry or PK polycystic kidney disease, there's always, well, now there's more treatments that are approved or are about to be approved.
Yeah.
And then again, in these diseases, in these genetic diseases, most of the time it's kind of chronic thing, a damage that's kind of slow and progressive. So if you put a brake on the progression of the disease, you might be able to buy a lot of years.
Yeah, buy time. You buy, and that's quality time too, because the patient's not progressing quickly.
Absolutely.
Yeah. So that part of the family planning, that's very interesting, because people do want to know. They want to know. I remember back when I was transplanted, my brother could have very well had FSGS too, and we didn't even know about it. And that was 30 some years ago. And so, I mean, that's why our genetic testing becomes, I think, very, very important and wise for family planning.
Absolutely. Yeah.
So I would say, here's another interesting thing. One of the questions that I had was, what about 23andMe? Can you tell me anything about that?
Yeah, absolutely. So this is kind of a fun, probably a lot of the listeners have seen commercials about getting the ancestry, so knowing where your origins are from, how many percentage are your ancestors are from Europe or from Middle East or from Africa, so forth, right? So this test is takes your DNA through a saliva or mostly through saliva. You send kind of a kit and then you send it back. And they offer to test particular genes and looking at the variants and risk factors to develop diseases like diabetes, Alzheimer, breast cancer. And then the most common things, or the fun part about getting these tests, is knowing the ancestry, some traits like the eye, hair color, and kind of telling you you're more prone to gain weight, so be careful and so forth. But in my mind, so they definitely say it's not a diagnostic test, so you should not use it to know if you have a kidney genetic disease or another genetic disease. Now, there's I think an option where you can buy the raw data and get the whole kind of sampling, but you need a genetic expert to go and
through it anyway, right? Yeah.
So I would probably say it's more of getting these general idea about your general health, but it is not trying to diagnose if you have or have not or don't have a genetic disease.
Yeah, we don't want to think, well, if I want to think about kidney disease, we don't want to do one of these tests. We want to go somewhere like at Mayo or a place where they're actually doing it correctly. Is that right?
Yeah, you want to go to if the main focus of the family, if there's kind of concern, there's something is inherited within the family, go to a genetic expert. If it's mostly kidney, go to a nephrologist with expertise and inherited kidney diseases, and then they can guide you in terms of getting the right genetic testing and what to do with that.
So is it, a lot of people now in this last year, people are unemployed. And is this expensive? How expensive is it?
Right. Cost of healthcare is always a concern. Genetic testing has been in the past historically known to be very, very expensive in the past. But things have evolved in an astronomical rapid way that is almost as inexpensive as an ultrasound or CT scan or so forth, right? So
Right.
it used to be in thousands of dollars and very hard to access that, even if you have the money. Now it's becoming much cheaper and several $100s or even less. And then not only that, there's now becoming like panels of genetic
Right.
testing, right? So
yeah, panels, and there's lots of companies doing this, and I've had a couple of them on, as a podcast. But kind of explain, if you can, current genetic testing programs. Like Riata and Natera has one.
Sure. Yeah. So as we just mentioned, having the diagnosis is important because without having a early and accurate diagnosis, you cannot treat the disease. So the companies that you mentioned, so Riata and Natera. So for example, Riata has
Kidney Code.
Kidney Code. Yep. And it's kind of a sponsored, so it is a free of charge genetic test. It's a very targeted one, so only 18 genes that have the ones that can cause Alport syndrome, for example. They have one of the PKD genes, and they have some other, what we talked about, the tubular interstitial kidney disease. Like, we're not going to mention all these complex.
Right.
So they have a targeted for few kidney diseases. So it's not a comprehensive one, but it's if you have, let's say, concern about Alport syndrome, it's probably a good test to do. And since it's sponsored and free of charge, it's always welcome to take advantage of that. So that's one way to do it, and I believe they have genetic counselors with that. We'll talk about it as well in terms of how important the genetic counseling is.
Exactly, and I think like Natera has Renasight, which is like you were talking about. Most of them are saliva. You send it off, and you get the results back. But you do need somebody to kind of review that. You can't just say, "Oh, look, it's negative," or "Oh, they said this or that." It's very specific. And it takes interpretation. It's not something you can just readily understand on your own.
Right. So it's not your typical, let's get a creatinine to know what the kidney function is, right? It is something that you need to have first a suspicion of a certain category of diseases. So if you have a kidney disease and there's possible family history, or even without the family history, there's some features where you think there's potentially a inherited kidney disease, probably your likelihood of finding the defect and having the diagnosis would be much higher. Now, most of the times it should be a kidney doctor or a genetic expert, geneticist.
Sure.
With Natera, it's a little bit more comprehensive, and to my understanding, the cost is covered by insurance, and if it's not, they offer good support. So it's
absolutely
accessible, actually. So if I would quote, it's probably not going to cost you more than $150.
Yeah.
And most of the times much less. So just for people to have a little bit of a reference of what
it costs. Yeah. Sometimes they roll that into the visit too. If you go into the visit with the nephrologist and they decide to do genetic testing, it can be rolled into the cost of that. It does get covered.
I think it's a separate charge that goes through but they have a support because I sent a few of them recently, and they have a support system where behind the scenes they have somebody who calls the patient, the insurance.
Okay, good.
Take care of because it is difficult for the physician also if it's going to take 2-3 hours to send a test. It's going to become more difficult for the physician to do it. So they
sure.
And there's other than the commercially available, so those have quick turnaround. So within a few weeks, you should have the result, 2 to 3 weeks usually. And then there's other research things. So we do our own research tests. We have also a big panel for kidney cysts, trying to discover new genes that can cause the kidney diseases and kidney cysts. So we offer those as part of our program, research-based, so free of charge. But those take a little longer because it's research tests. So
well, sure, and yeah, and I just wanted people to understand that, this sounds like, something way out, like a space odyssey type thing. It's not. It's becoming very common now, and it's very definitive. It can help a lot in caring for someone with kidney disease.
Absolutely, yeah. I can give you many examples. I had a patient, young female in her 30s, that is kind of needing transplant. So she's nearing the need for transplant, and she has seen probably 5-6 nephrologists so far, and no one could give her a diagnosis. And then looking more at the history, her mother had the same thing in her 30s, 40s, went on dialysis, got transplanted, doing great. But so we sent the genetic testing for her, and then we got the diagnosis that this is an inherited tubular interstitial kidney disease. And now she knows what to expect. So it's very powerful to have the diagnosis, because you're not questioning, do I have a lupus? Do I have autoimmune disease? Do I have something, unclear or uncertain? Now you have the diagnosis, you know what to do, you know what's the prognosis of that disease, so you know what to expect. And then you help also your kids, if they have it or not, to help.
Absolutely. Yeah, because you don't, when you get a diagnosis of kidney disease, and your father went through the same thing, and knowing your father has PKD, it's got to be on your mind.
That's a whole topic on how a chronic, so knowing that you might be at risk of a genetic disease, especially with PKD, because it's the most common, and then there's families that have many members throughout generations. So they've always seen how their grandparents have, maybe did well or didn't do well on with dialysis, transplant, so forth. So the patients or the family members who might or might not have the disease, they have this bias and they have this experience that accumulated throughout the years, that what PKD is, right? So and if they have a positive experience, that's great. But then if their loved ones didn't do well, then that's going to affect them negatively. And then they're going to start thinking, do I have it? I don't have it. And then if they do, then they're going to say, okay, they're going to probably get depressed if their loved ones didn't do well, right? So
they look at that as experience. Well, is that going to happen to me?
Exactly. Right.
Yeah.
So living with, so it's important, knowledge of things is important. Now we have more understanding. If you have even the same disease, it doesn't have to be the same path that you take as your other loved ones. There's so many other factors. For example, for polycystic kidney disease, there's so much variation even within the same family. Some might have a very mild disease, some might have a very severe disease. So there's other factors that we're trying to understand, and we can tell based on imaging and the genetic tests and other things. So so science has improved, very fast over the past decade or two. So I advise all your listeners to kind of come in and with an open mind, remove those biases, and just kind of think of what you have or you don't have. And then if you have the disease, try to understand how severe it is and what the future will look like.
You know that I work really closely with a lot of kidney patients.
Yep.
And one of the things that I hear all the time is, well, they didn't tell me anything about that. I didn't hear that. I didn't, nobody told me about my options. Well, that's okay, but genetic testing kind of unfolds or unwraps that kind of unbelief or non-belief, and you can really then become, gee whiz, I understand now. I see this. My dad had it, my mom had it, or whoever, but that genetic test will say, here's what we really need to do and what you need then watch out for later on down the road, right?
Yep. Yeah, absolutely. And sometimes, when you get a diagnosis, and then you get so much information, like
Yeah.
an hour of information. Maybe not a lot of things are gonna, you're gonna forget many of these things. So it's important for the patients to be their own advocates and their family members to be their advocates.
Great.
You know,
Absolutely. Absolutely.
you have to advocate for your health. Otherwise, it's not gonna go well.
Right. You know, you're the kind of doc that I like to talk about and with, because you're what I call an option doc. You give a patient options. You don't just say, well, this is what we got to do, or that. Here in a nutshell is what you have. And because of genetics, we've been able to test with that. And it's possibly that it's going to roll out through the rest of your family. So we need to be testing them too. Yep. But my point is, you tell them, you give them options, and that's great, because then they can make a conscientious decision on how they're going to treat themselves. Get treated.
Yeah, they have to have enough information to make a decision, but at the same time, there should be a shared decision. So
exactly,
I have the expertise, so I can tell them what might or might not work. So we shouldn't also let just the patient take they should take their own decisions, but they should also be guided by the experts.
Absolutely.
And doctors. Yeah.
Absolutely. What's the use of going to a doc if you're not going to take his recommendations, right?
Yeah, shared decision. So
shared decision.
Find a good option for the right time.
I have two really good friends in the PKD community, and I want to just give in a quick jab or for them. One of them is Jim Myers. His dad, his whole family had PKD, and he had PKD, and he had a transplant. And he's very active in the community. And the other person I want to talk to wrote a book called The Reluctant Donor. Mm-hmm. Have you heard of that book?
Yes.
The Reluctant Donor, Suzanne Ruff, very good friend of mine. And she took the angle of what it's like to be a donor in a PKD family.
Yeah.
And I would encourage my listeners to please read this book. Pick it up. I don't care if you got PKD or not. It's got a lot of things that are very interesting in it. And I know that you probably recommend this to your patients, so it's good.
Yeah, absolutely. I mean, I always say PKD is a family affair. Because even if you have it or you don't, you're going to be affected, because similar to the reluctant donor, she was affected by PKD because she had a decision to give to her affected sibling. And so everybody has skin in the game in a sense.
Absolutely. Great point. Great. Yep. If you don't, shame on you. You really need to be all in. Yeah, that's right. That's right. Okay. So, like from a doctor's perspective, how does a genetic diagnosis change your management of a kidney patient?
Yeah. So if we know exactly, that the patient has diabetes for many years, wasn't controlled, and we know exactly what's the cause of the kidney disease, great. It's good to know, and we'll just kind of deal with the consequences and try to prevent further damage. But if we say chronic kidney disease of unclear etiology, that shouldn't be accepted anymore. Probably there's still a lot of unknown diseases that we still have to discover, but these days, we have the access to the genetic diseases, so we can try to at least give the first shot. And there was a study with more than 3,000 patients, and they found at least 300 patients with genetic causes. So they pinpointed exactly what's the cause and what's the gene. So that's gonna whenever you have the right diagnosis, that's gonna affect your management right away. Because you know what you're dealing with, you know what to expect. And then if there's other extrarenal, so things outside of the kidney that you need to deal with. And then again, if they reach the need for dialysis, what you're dealing with after, the need for transplant, what exactly you're dealing with after the transplant. So that's very important. I can give you an example, about a kidney cyst patient. So he was diagnosed. He had multiple kidney cysts, on both kidneys, and he has a long, strong family history of kidney cysts. And then his aunt, mother, other relatives had kidney cysts and went on dialysis. But then when you look at his kidneys, it doesn't make sense that his kidney function is such, it's very low, and he doesn't have a lot of kidney cysts. So we figured that that doesn't match, what we call non-congruent. So his kidney function and how the kidneys are looking, they're not matching, and they don't look like autosomal dominant polycystic kidney disease. So we did the genetic testing, and we discovered a new gene. It's called DNA JB11, for example, and that. Once we discovered that, we also went back and we found 10 other families who have similar genetic disease. And then we figured how the clinical course is. So apparently, the patients would stay with very normal kidney function for very, very long. And then if you look at the kidneys, you say, okay, don't worry, you're never gonna reach dialysis. But apparently, once they reach like their 6th, 7th decade, the kidney function
take a dive.
Takes a dive. So knowing the prognosis and knowing the clinical course, natural history of the disease, whatever that is, kidney cysts or other things, is important because that informs the patient. Okay, I'm in good health now in my 50s. Then I need to be prepared for my 60s. It's not going to look good. So let me do my things, right? So let me do things in order.
Get my life in order. Yeah.
Let me do I know of a trainee actually. So, well, maybe we should not talk about that. But a lot of times people who have, we can actually. It's not HIPAA violation.
No, it's not. No names. Yeah.
So, a lot of people from here and other places, if they have polycystic kidney disease or other diseases, they understanding what's going to happen and when they decide, for example, to move to a certain area close to a bigger kidney transplant center.
Yes.
They change their career sometimes. They decide to go to private practice and say, okay, I'm going to retire at 60, I'm not going to keep working.
Right.
So it has a lot of implications in terms of how you guide your life in general.
So that we put this in perspective, you can have a biopsy, you can get a diagnosis, but the genetic test is an add-on to that because it gives you an idea of a prediction. Right? Is that essentially?
Yeah. So sometimes the biopsy gives you again the generic, whether it's early or most of the times we do it very late in the game. And if you just have the kidney is scarred and we cannot tell exactly what's the cause, and particularly the genetic diseases, there's not a lot on the biopsy that we can tell, except the glomerulopathy, so the things that affect the filters. So there's a lot of different categories. But in general, the biopsy might not be as helpful if it's done late. So the genetic test is always going to tell us if this is an inherited kidney problem or inherited disease and what it means. Now, it's not always straightforward. So sometimes we find just a variant, right? So because we have the same kind of genetic background as people, but there's variance within each gene, and it doesn't mean that if you have a certain variation, most of the times it's normal to have these variations. So we look at how many in the population have this type of variation, and if it's commonly seen in the general population, most likely this is non-pathogenic, so it doesn't cause a disease. So what I'm getting at is when you do these genetic testing, you might get these variants of unknown relevance or
sure.
So those have to be put in context with your disease, trying also to get genetic testing for your relatives, see if they have similar symptoms or diseases, and if they do or don't have, then it's an important information to figure out if what you have is the cause of your disease.
So let's say, for instance, I get a result back and it's inconclusive. And I'm not talking negative here now, or normal. I'm talking inconclusive. So explain that. How does that work?
Yeah. So, and a lot of times if it's let's say polycystic kidney disease, in probably 97% we will find either PKD1 or PKD2. And then in a very small percentage, we won't find any problems with the gene with a genetic test. Now, if you're not looking for the exact gene, you're probably not gonna be able to find if there's a defect or not, right? So when we go, for example, we have a typical polycystic kidney disease patient, the classical, then we look at PKD1 and PKD2, and those are the two most common genes, for example. And then now that we're discovering those small percentage of patients who have also kidney cysts and inherited kidney diseases, now we're including them in the panel. So instead of just looking for two kidney cystic diseases genes, we're looking for actually 350, 380, and it keeps growing up.
Right.
So genetic testing, when you do a DNA sample, it's not gonna look at all your genes. There's thousands and millions of genes. So it has to be targeted. So let's say you send that targeted panel, whether through the commercially available or through the academic centers, and then it comes back and says you have a certain changes, variation in one of the genes. So in that situation, again, we have to take other blood samples from or DNA samples through the saliva from other family members, look at their, for example, their kidney function, kidney tests, and their how their kidneys are looking, for example, and then make sense of these variation and see how often we see that in the general population, because we have databases where we know that this particular change is probably seen, 10% of the times in the population. That's probably normal because it's impossible for something to be this common.
Right.
This variation can cause this much problem, right? So we have certain rules and that guides us. Now, if it's still inconclusive and we're not sure, we're still highly suspecting a disease, we go to something called whole exome sequencing. So we kind of take a bigger look at your whole DNA, and then try to use big computers to figure out what's normal, what's not normal, and then compare it to your family members and so forth.
So like with PKD, it's very family oriented. Most of the people get it and some don't, but the whole point here is there's other disease processes that are a lot more, I guess, very difficult to focus on, to really get to the bottom. I speak of FSGS, and you mentioned about how that can recur. You know how, and I know of several of my friends who've had one or two transplants, maybe even three transplants, because of the recurrence of the disease process.
Yep.
So genetics is very important in trying to figure out what type of FSGS you have.
Absolutely. There's at least, I'm looking now at the list of, for example, FSGS, how many genes. And for example, in the panel the Natera has, there's, I can see almost 10 different genes that can cause FSGS.
Yeah.
So knowing which one is important, first to diagnose that it's that type of FSGS. It's not the one that you just acquire.
You acquire, yeah. Mm-hmm.
Yep. And then second, once you have that, it's important to have the very regular monitoring.
Sure.
And the future is bright. I mean, we're talking about kind of these gene therapies. Even if there's a very rare disease, we can still do like gene therapy for only one patient. So that's probably coming up. It's not in the next probably 5 years, but maybe in the next 10 years, we'll start offering, if you know exactly what's your disease, we can fix it very early in life and we'll just monitor you kind of don't worry.
That's what I want to close on today. I want you to put your baseball cap on and sit back and dream and think. And what do you see coming down the pipe? What is right now the most interesting and probably good thing in kidney disease is coming along? Can you share that with us?
Sure. So there's probably multiple things, and we can probably go on with many sessions.
Yeah.
But let me give you a couple of things. So one is, since we're talking about the genetic diseases, is early treatment with. So now we have gene editing techniques, which are very controversial with the ethical background of it.
Mm-hmm.
But I'm sure we can find a way that the science and ethics merge together, and we don't have a problem because we're saving lives. So with using these very new techniques, the gene editing, we can go in and fix the DNA problem. And things have been started to do these gene therapy. People have been doing these gene therapies now. For example, for only one patient, they will create a whole technique and whole changes for only one patient with this specific defect. It costs hundreds of thousands of dollars, but in the future, it's going to become more accessible, and it's going to become probably the standard of care for FSGS, hopefully for PKD, although it's a little bit more complex. But this is kind of where I hope we can, that's where we talk about cure.
Exactly.
So you're curing your disease. Everything else is treatment and trying to advance the therapies. So that's kind of hopefully a big goal for the science, is to cure these genetic diseases early on and just save lives and lives just through that.
Yeah, go ahead. No, go ahead. Continue.
Sure. So the second one is probably the artificial kidneys, and it's been a dream for so many years, and it didn't really pan out early on. But I think there's now a different approach, and there's an understanding from the U.S. government, from the societies, the kidney societies, that this should be a priority, because we have so much need for kidney transplants that we cannot provide.
Can't keep up.
Right. So the demand is higher than what we can give. So we need to find a way where we can create your own kidney. So the dream is, hopefully in the maybe 10 years, is that we take, let's say I have kidney disease, I'm about to be on dialysis, and I know kind of it's slow and I'm getting there. So before getting there, we'll get some stem cells from my skin, and then we'll grow these stem cells in the lab, and then we'll grow a specific kidney for me to be donated at a certain point, in a pig or an animal, or so forth. So this is probably that kind of 10-year, 15-year dream for.
But that research is going on. I know that research is going on.
Yep. Yeah. I mean, imagine, 10 years ago or so, maybe we didn't dream that we have iPhones, right? Or we would do FaceTime. That was only in science fiction.
Right.
So I give this similar analogy that there's hope, but at the same time, we shouldn't just stay and dream. We should do what we can and improve day by day our management of kidney diseases. And then with PKD, for example, my personal goal is to find a cure or get cures. But meanwhile, because it's a little bit more difficult with PKD1 gene, the most common, it's a big gene and it's hard to do the cure. But meanwhile, we need to find new therapies we can start. So multiple breaks. So right now there's an FDA-approved drug, the one FDA-approved drug for PKD, ADPKD. So that's amazing. That can put a brake on how fast the disease is going to progress.
Yep.
But hopefully we can find more breaks so that would really stop it. Maybe multiple drugs that can just put several breaks and then it stops the disease early. So that's where my goal in seeing the patients and being in the lab and create these new therapies. So that's where I'm trying to put my effort in.
Well, you're not trying, you're doing it. I know. And we can go on. I would love to go on the rest of the day, but I know that can't happen. I just want to let people know that the most important thing about genetic testing is you get counseling with it. I think that's the takeaway of this whole process.
Absolutely.
You can get all kinds of testing done, and you can spend all kinds of money doing it. Mm-hmm. But a professionally guided, medical guided genetic counseling program, if you want to really explore that, that's what you need to do, because you get counseling with that.
Yep. Yeah. Never do a test without knowing what you're going into.
Exactly.
Anytime any test, it doesn't have to be only genetic, but genetic is more sensitive.
Sensitive, yes.
You need to have the right people that can guide you and explain exactly what's going on and guide you through the process, because it can be taxing to you.
Well, you don't have the experience. You can Google everything you want to, but you can't Google genetic testing because it's very specific. I mean, it is multiple things that go on with the test itself, but the interpretation of it comes with experience.
Yeah. Dr. Google is usually the worst idea, but good to be informed because
it gets you started.
Dr. Google gives you the worst case scenario, and it's typically not the case. So you're gonna make yourself you're gonna put yourself in such a position that you're better off just talking to your doctor for 10 minutes.
Exactly.
Solve all this. Yeah, we do it all the time, but yeah, it's important to know the limitations of these search engines and really, go to the experts and whatever disease you have.
Well, I know you're open to many more questions and many more ideas, but I think we're going to call it an end. We're going to cease and desist, but would you come back again and
Absolutely.
talk?
Yeah, definitely.
Okay, so we touched on everything. I just hope that people understand that this is something that's coming, and it's coming fast.
Yeah,
it's going to get less expensive. It's going to be more decision making, and the thing of it is, it's going to create the C word for people like me, cure.
Yes.
Just had a nice talk in a session the other day, Neptune, the University of Michigan, and part of that program there. And one of the things that this group of 14 people brainstormed was, and they were all kidney patients. They were asked, what is it that you would like to see in the kidney space that would be the most important thing to you? And to all 14 of them, the number one was cure.
Yep.
And so you are on the right track, my friend.
Yeah, a lot of I've experienced it firsthand how chronic kidney disease can just take everything out of and if you don't have the right team with you, it can be difficult. I can give you so many examples. My dad, when he was diagnosed with PKD when he was uremic, so he was about to be started on dialysis.
But most people with kidney disease, they'd live it, look fine, act fine, are fine in everybody's eyes except theirs. They know they're sick.
Yeah.
And I can tell you that if you have chronic kidney disease, you are very ill. I don't care what stage you're in.
Sure.
It's always progressive. I don't care what statistics are. Kidney disease is progressive.
Yep.
And so you need the best care possible from the beginning, and you need to be watched and coordinated that care all the time for the rest of your life, because it doesn't go away. Yep. There's no cure.
And you need to have a good support. So without my mom, my dad didn't have me. So you need somebody who would pick the phone and fight for you.
My 51 years of marriage is a tribute to that. So I know what it is, and that's what we say with Kidney Solutions. We're here for you, and we're going to stay here for you, and we're going to go till the end, or till you fire us, one of the two. Listen, I want to thank you so much. I do appreciate it.
Absolutely.
Let me tell everybody goodbye and then stick around for a second. Okay, folks, listen, this has been a very good podcast, and it's very informative, and we're gonna have some time to think about this and go back and listen to it a couple of times. I ask that you share this with people, get the word out about kidney disease, especially about genetic testing, because it's coming and it's coming quickly. Things are changing in the kidney space, but it's up to us to keep making sure that we maintain it and that we talk about it. We get it out there. So when you listen to this, share it, get it out there, and let people have a chance to listen to it themselves. So until the next time we do a podcast, keep breathing.